Greetings to all the delegates. We have started the RSSDI 2020 with a bang, and COVID situation notwithstanding, we have a digital extravaganza with us and an academic feast. So today I bring to you the updates of the first day of the RSSDI. I'm going to show you some highlights of today. So as I said, today was the first day and we have a lot of interesting lectures that have happened, and I'm going to show you a little bit of a snapshot of the same thing. So the first thing that was discussed today was about modern SUs. We all know that SUs are very important to us because we use them a lot, they're cost effective, and how a modern SU can add years to life in a patient with type 2 diabetes was what was discussed. Diabetes is linked to 9 years loss of life due to complications. That was what was discussed. And these complications, both microvascular and macrovascular, affect the quality of life and cause early death. And in a study of 160 Danish subjects with type 2 diabetes and microalbuminuria, they studied the progression to macroalbuminuria, and they showed that it reduces with intensive care, and this was included in the primary outcomes. And to study the effects of intensive care on neuropathy and retinopathy progression, they were included in the secondary outcomes. And the results and conclusions of this study were very, very impressive. Modern SU in type 2 diabetes led to 70% reduction in the risk of hospitalization for heart, was the impact of the intensified multifactorial intervention, and lifespan was increased by 7.9 years. Therefore, intensive treatment arm experienced a reduction in nephropathy and macrovascular complications. The legacy effect was observed even after the end of the treatment period, and at 21 years, intensified multifactorial treatment added a median of 7.9 years of life to a patient. So this was about modern sulfonylureas. The other highlight is about metformin. Does it still have a supreme position as first choice, and what are the pros and cons? So as we know, most of the guidelines still favor the drug metformin as the first line agent in patients of type 2 diabetes because of its safety, effectiveness, long-term experience, and cost advantage over the newer drugs. So the metformin treatment for 1 year in 1,000 patients showed 5 fewer deaths in place of diet and 3 fewer deaths in place of SU or insulin. So this was one of the highlights. And to summarize this part of the proceedings, in patients with a contraindication or who develop intolerable adverse effects to metformin, SGLT2 inhibitors and GLP-1 receptor agonists may be considered, but care should be taken to personalize it. To date, metformin does not show any lethal complications or drug interaction like all other agents, and every complication is manageable. Metformin's robust efficacy, the security or the safety profile, the beneficial CV and metabolic effects, and its capacity to be combined with other anti-diabetic agents makes this old drug the first glucose lowering agent of choice when treating patients with type 2 diabetes. So this is one of the highlights of today. Another very, very interesting talk was about newer clusters of diabetes in Indians. Patients with newly diagnosed diabetes from the Swedish all-new diabetes in cohort was included for analysis, and clusters were based on 6 variables: GAD, age at diagnosis, the BMI, HbA1c, and the HOMA beta and the HOMA IR. So the key points from this particular lecture was that there were novel subgroups of adult onset diabetes, namely severe insulin deficient diabetes, severe insulin resistant diabetes, mild obesity related diabetes, and mild age related diabetes. The clusters remained stable even when tested with data set newly diagnosed diabetes less than 3 years and less than 1 year. The ICMR INDIAB data shows that clusters identified in the clinic population are replicable and stable at the national level. The Jacquard Similarity Index was greater than 0.75, which confirmed that the cluster allocations were stable with less variables. The conclusions were that for the first time in India, clustering was done in individuals with type 2 diabetes using 8 clinically relevant variables. 4 replicable clusters were identified, 2 of which were the same as in the Scandinavian clusters. However, two were novel and unique to the Asian Indian population: insulin resistant onset diabetes and combined insulin resistant and deficient diabetes. The novel cluster CIRRD is of particular importance as it is characterized by difficult to control hyperglycemia and increased hazards of kidney disease and retinopathy. So we come to the next highlight, and that was about the twin cycle hypothesis. So the pathophysiology of type 2 diabetes was believed to be characterized by progressive irreversible loss of pancreatic insulin secretion mediated by apoptosis of pancreatic beta cells. At the diagnosis of type 2 diabetes, beta cell function is typically reduced to 50% and to a greater extent on dynamic testing. This is what was thought. Loss of the fully differentiated phenotype is a recently recognized potential mechanism underlying loss of beta cell function in type 2 diabetes. So in general, diabetes was earlier regarded as an inevitably progressive disease. But the twin cycle hypothesis tells us that this may not be the entire truth. The theory postulates that chronic calorie excess contributes to liver fat accumulation with subsequent spillage into the pancreas, and these self-reinforcing cycles between the liver and pancreas eventually cause insulin secretion after meals to be metabolically inhibited and hyperglycemia to begin. And to summarize this part, type 2 diabetes is a reversible syndrome, at least in the early years. The characteristic beta cell defect can be abolished by dietary means alone by decreasing the fat in the pancreas. Dietary energy restriction rapidly decreases the liver fat to return to normal hepatic sensitivity. The extent of the weight loss required on average to reverse diabetes is around 15 kgs. The twin cycle hypothesis has elucidated the etiology and pathophysiology of type 2 diabetes beyond mere insulin resistance and insulin deficiency. There are events that occur upstream in the cascade above insulin resistance and insulin deficiency, and this hypothesis gives a better understanding of the interaction between environmental factors, mainly overeating, and genetic influences, mainly muscle insulin resistance. Then coming to another very interesting highlight of today's talks about the beta cell, from failure to dysfunction to de-differentiation. So beta cells in type 2 diabetes patients which escape the fate awaiting those beta cells which persist in their attempts to produce insulin and ultimately succumb to cellular stress and apoptosis by undergoing de-differentiation. And the therapies for diabetes potentially can be to replace the hormones such as insulin, replace the cells themselves such as in islet cell transplant, or regenerate the cells which are there through proliferation, neogenesis, or transdifferentiation. And therapies for diabetes include those that can replace hormones, replace the cells, and regenerate cells, as you can see in the slide above. So to summarize that part, insulin resistance has long been seen as the primary cause of the disease, while the result of beta cell loss has been considered, indicating exhaustion of beta cells in an attempt to resolve the insulin resistance by continually increasing insulin production. Emerging evidence indicates that beta cell de-differentiation can play a role in beta cell failure in type 2 diabetes, and beta cell de-differentiation involves loss of beta cell gene expression and upregulation of genes not normally expressed in mature beta cells, including those expressed in islet progenitor cells and other mature islet cell types. And developing redifferentiation approaches for these cells may lead to the restoration of a functional beta cell mass. So these were the highlights of the first day of the digital RSSDI 2020. We will be back tomorrow with the updates of tomorrow's sessions. So please tune in and watch this space.